Good evening and welcome. Good evening and welcome to the APNA Obesity, Chronic Disease and Fertility webinar. We're joined tonight by our presenters online, which I'd like to introduce you to briefly before we get started. Ruth Mercer is a highly experienced registered nurse who spent almost 17 of her 25-year nursing career as a primary healthcare nurse. Ruth is an endorsed nurse practitioner and works as an integral member of a multidisciplinary team within a suburban general practice in Newcastle, New South Wales. Jo Perks lives in Sydney and is a nurse practitioner who has worked extensively in women's health services in New South Wales for over 20 years. Amongst her many roles, she is also an active member of the Education Committee for APNA. Thank you, Ruth, for now starting our presentation today.
Hello everyone. I'd just like to say a big welcome from all of us, and I hope you enjoy the webinar tonight. So by the end of the session, we hope that you'll be able to identify some strategies to better engage with both male and female clients in relation to their fertility and their future pregnancy planning options. Hopefully you'll be able to explore some of the impacts of chronic diseases and risk factors on fertility and the subsequent impact on antenatal care and birth outcomes, and hopefully identify some issues relating to being overweight and obese and the role of weight in fertility, pregnancy, birth, and birth outcomes. Hopefully you'll be able to comprehend the impact on fertility, pregnancy, and both outcomes on specific chronic diseases such as diabetes, mental health problems, epilepsy, and autoimmune disorders, and also improve your understanding of the valuable role that us as primary healthcare nurses have in promoting and encouraging fertility awareness and planned pregnancies to clients within our care.
Hi everyone, it's Jo here, and I would sort of agree with Ruth. I hope you all enjoy the presentation and get out of it what you need to. Through the course of the presentation, we're going to have some polling questions, and we already had one around who you are with for tonight. So if you could have a look at this one, it's do you routinely discuss fertility and pregnancy planning to patients within your care when undertaking chronic disease management lifestyle modification programs? So there's already people filling that one in. Okay, so that looks like it's probably exhausted now, and that's great. So some are and some aren't. So you know, I think that it's really worthwhile us doing this presentation. So we'll move on from there. So the next slide talks about primary health care in Australia, and I'm not going to read it out because you can all read it there, but I'm going to just make some points about primary health care and consider our role as nurses who are working in the primary health care setting. And we have quite diverse roles in primary health. So, for example, I work in a women's health centre. There are other people who are participants tonight who are working in general practice, whilst others are in corrections health and are school nurses. So I think, you know, that whole ideal about primary health care is around health promotion, illness prevention, the treatment and care of sick people, rehabilitation and palliation, community development, population and public health, education and research, policy development and advocacy. So thank you to those working in primary health care, because I think we're all doing a fantastic job. So with the topic theme of being obesity and chronic disease, I'm going to give you a bit of a snapshot, and you can see there that there are some stats from the Australian Bureau of Statistics from 2012. And we know that obesity and overweight are definitely increasing and form part of, you know, a lot of the chronic disease management that we all do. But they also have a major impact on fertility. So there's been a notable increase in the rates of obesity worldwide. The prevalence of overweight and obesity within Australia has been steadily increasing for the past 30 years. In 2011-12, around 60% of Australian adults were classified as overweight or obese, and more than 25% of these fell into the obese category. Having excess body weight increases a person's risk of developing a range of long-term health conditions such as type 2 diabetes, cardiovascular disease, arthritis, cancers, high blood pressure and high cholesterol. And I know that in my practice, and you're probably the same, Ruth, I'm seeing a lot of young women with polycystic ovarian syndrome, which can impact on their fertility, and we're going to talk about that tonight as well. So being overweight impacts on both male and female fertility. When a woman is overweight or obese, she may overproduce estrogen, and as estrogen is required in ovulation, the menstrual cycle can be affected. And again, that example about PCOS, so in some of my clients, their cycles are out to 60 to 90 days between periods, and that does become a problem when you're trying to conceive a pregnancy. The imbalance of hormones due to obesity may also result in insulin resistance, altering the hormonal environment of the ovaries and thus impacting on fertility. So contraception in relation to obesity, you can see that obesity affects the eligibility and suitability for certain forms of contraceptives. And for those who've joined our other webinars over the past, I think we've talked about the medical eligibility criteria, and that is around looking at guidelines for prescribing of all of the contraceptives that are available in Australia. And that there are different eligibility criteria for each one, such as the pill or implanon, for example. It provides an evidence-based framework for assigning a risk category for the use of a particular contraceptive method in specified conditions. And Family Planning New South Wales have produced a guideline around contraception, which looks at that medical eligibility criteria. So Family Planning New South Wales advises caution for obese women with multiple risk factors of venous thromboembolism, cardiovascular disease and stroke, advising that an alternative non-estrogen containing method is preferred. The progesterone-only pill, commonly referred to as the mini pill, is generally a safe option for obese women, as is the etinogestrel implant or Implanon NXT. The copper intrauterine device and the levonorgestrel intrauterine device, or Mirena, are suitable options for women who are obese with a medical eligibility criteria of Category 1, which means that the benefits are outweighing the risks of that method. Barrier methods of birth control, including condoms and diaphragms, are options worth considering. However, consistent and perfect use is imperative due to the relative risk of adverse events associated with an unintended pregnancy. So contraceptive failure may result in an unintended pregnancy, and as mentioned earlier, so does the increased risk of adverse events related to obesity in pregnancy. And obesity is not a contraindication in the use of the emergency contraception. So I'll now hand you over to Ruth again.
Okay, so we're now going to have a little bit of a case study, and we might introduce Isabella. So Isabella presents as a new patient to our practice, and we're going to look at what her story is. So Bella attends our practice, and she's a new patient, and she presents with concerns of amenorrhea, nausea, and some breast tenderness. She does give a history of some irregular menstruation. She and her partner have been in a steady relationship for the last 4 years. She's sexually active with her partner of 4 years, and condoms are used at times for birth control. Bella's weight is 92 kilos. She's 166 centimetres tall, and it places her in a BMI of 33.4, which is actually in the obese categories. She has no known allergies, no medications, and no significant medical, surgical, obstetric history. Isabella is seen by both a primary healthcare nurse and the GP, and following some investigations is found to be approximately 16 weeks pregnant. Isabella is delighted. What might Isabella's pregnancy look like?
Okay, so in the antenatal period, Isabella has an increased risk of having a miscarriage, developing gestational diabetes, developing hypertension during the pregnancy, developing preeclampsia, developing, sorry Ruth, OSA.
Obstetric sleep apnea.
Yes, thank you. It's too late in the evening for me. And an increased risk of maternal death. all due to being obese. So I was actually going to say Isabella is delighted, but possibly the people that might be caring for her are going to talk to her about some risk factors there that are related to obesity.
Yes. And during her interpartum period, Isabella is at increased risk of requiring an induction, having a prolonged labour, and also failing to progress. Because of that, she's got an increased risk of requiring a cesarean section and also having a baby born prematurely and requiring special and intensive care on delivery. And this is all to do with actually her size.
So it doesn't end with the antenatal care and labour and birth and delivery. There are also issues that can happen in the postpartum period. And again, you can see on the slide that there are those risks with congenital abnormalities, particularly if gestational diabetes is a consequence of the obesity. Neonatal consequences, increased risk of developing postnatal depression, greater likelihood of needing support with breastfeeding establishment and continuation. So maternal obesity, to summarise, is a major issue in obstetric practice in Australia and New Zealand. It is important that women with an elevated BMI are offered nutritional and exercise information in both preconception, during pregnancy and post-pregnancy from appropriate specialists. And I know that with my role as a women's health nurse practitioner, I do a lot of that opportunistic preconception care and screening, and I'm sure that Ruth and probably most of you out there are doing that as well. This ensures that women are supported appropriately in safe weight loss preconception, appropriate weight gain during pregnancy, and appropriate weight management after pregnancy to minimise postpartum weight retention. So the key messages, have the conversation. So don't be afraid to talk about the weight issue, because I think a lot of us are actually afraid to, or fear what the client might say if we start talking about losing weight and weight management. But I guess it's also about motivational interviewing around, what are your goals? You want to have a healthy baby, and talking about all of that sort of stuff. When speaking to male and females who are overweight or obese, discuss the impacts of fertility and obesity and the impact on not only their own long-term health, but also on their reproductive health and the outcome of any future offspring. Fertility might be the catalyst for change, as I talked about with that motivational interviewing. When speaking to an overweight or obese young person, the impact of diabetes, heart disease, hypertension might be viewed incorrectly as medical conditions that affect old people. The impact on their fertility might be the catalyst for change.
I think that's really hard-hitting when you think about the young people that you see in your practice, and you think about the men that come in too. Is realistically, because a lot of people may not realise that the males are actually for them to be overweight is actually counterproductive for fertility as well. And I think, like Joe said, if they actually realise that their own weight as a male might actually impacting on the chances of actually conceiving a pregnancy with their partner is huge. And again, like Joe said, that might be the impetus for them to actually realise they need to do something to motivate themselves to actually, it might not be about, they might not realise the significance of that, but the very fact that they can't father a child might be enough of a reason for them to start losing weight. So that's a big reason to start doing that. We're just going to move on to diabetes now. So as we know, and we see it in our practice every day, it's a growing concern. So diabetes affects approximately 1.7 million Australians are diagnosed with diabetes, and about 280 Australians develop diabetes every single day. And all types of diabetes are increasing in the prevalence. Type 1 diabetes accounts for about 10% of all diabetics and is increasing. Type 2 diabetes accounts for about 85% of all diabetes, and this is increasing, as is gestational diabetes in pregnancy. And the prevalence of diabetes is on the increase. Natural presentations within our primary healthcare settings are also likely to be on the rise. So when we see people with a diagnosis of diabetes, do you discuss reproduction, sexual health needs with them? And that's something that hopefully after tonight, it just might put that onto your radar. So think about that when you're doing your chronic disease management, is thinking about fertility. Ask those questions, obviously with age-appropriate clients that you're seeing. Is it something that's actually going to potentially impact on their fertility? Just a little bit of an insight into the contraceptive needs of women who have diabetes. In general, contraception advice should follow the same guidelines that apply to women without diabetes. But just bearing in mind that there may be comorbidities that are associated with diabetes that means that perhaps they are not able to use certain forms of contraception. So the combined hormone contraceptive pill may be contraindicated in the presence of diabetic complications or elevated cardiovascular risk that may be accompanying diabetes. So think about diabetic patients who are actually overweight. It may be that the fact that they're not able to be prescribed the contraceptive pill because of their obesity, not because of their diabetes. The progesterone-only contraceptive, such as the mini pill and the contraceptive implants and the merino IUD and the copper IUD, are perfectly good and perfectly safe for women who have diabetes. And also the barrier method is a safe option for women who have diabetes. However, remembering that the lower effectiveness of barrier method should be considered in relation to risks associated with unplanned pregnancy in women that have diabetes. So it's important to be mindful of those things.
Can I make a couple of points there, Ruth? Sorry.
Yep.
Just coming in, I have had a couple of endocrinologists in Sydney who have disliked Implanon for diabetic women or women with PCOS because they think it increases insulin resistance. But I've not actually seen any research to back that up. So, you know, maybe we need to check with the rep just to see what's happening with that.
Yep.
And I also just wanted to flag that the new, for those who aren't in the know, there's a barrier device called Kaya, C-A-Y-A, which will replace the conventional diaphragm from the end of the year. I'll just get your information. Thanks, Ruth.
Thanks for that. So preconception, obviously, preconception planning for everybody with diabetes is so important. So formal pregnancy planning should involve a multidisciplinary team working in conjunction with a general practitioner. Ideally, the glycemic control should be, for pregnancy, is imperative in reducing clinical risk factors. So what can we do? So when a woman with a pre-existing diagnosis of diabetes is considering a pregnancy, she should ideally undertake formal preconception planning involving the GP and a multidisciplinary team. And primary healthcare nurses are in a prime position during ongoing chronic disease management to openly discuss preconception with their patients and ensure that they are referred to specialist multidisciplinary team for management and pregnancy planning. Medications should also be reviewed before pregnancy to reduce the risk of women taking possible teratogenic medications. And also, like I said, glycemic control is super important before and during the pregnancy. So women with both type 1 and type 2 diabetics are more prone to pregnancy complications, as a pregnancy has a potential to accelerate diabetic complications. Obviously, medicine safety, like we've just said, is really, really important. And also remember that the men that you see who have diabetes, it might be just worthwhile just talking to a few of those men regarding the medications. And if they're already concerned about medications, it's actually important to have those things reviewed by the appropriate medical physician to discuss if there are any potential implications with the medications they're taking and planning a pregnancy. So it's important to talk to their endocrinologist, their GP, the pharmacist about the medications that they're actually taking. So pregnancy and diabetes. Glycemic control, like I said, is super important before and during the pregnancy, and poor glycemic control at conception and early pregnancy is associated with increased risks of congenital abnormalities and first trimester abortions. Both maternal and fetal complications are elevated when a pregnant woman has diabetes. Glycemic control is important before and during pregnancy because good glycemic control can mitigate the risk of maternal and fetal complications and the likelihood of birth trauma and reduce the risk of early induction and the need for a cesarean section due to fecal macrosomia, respiratory distress syndrome, CNS and cardiac defects. Pregnancy may accelerate some of the complications of diabetes, therefore complications need to be addressed before the pregnancy. For example, proliferative retinopathy may worsen in pregnancy and if present should be treated. stable non-prolific retinopathy is not a contraindication to pregnancy. So women with moderate to severe renal impairment are at a higher risk of complications. And there is also a higher risk of pregnancy-induced hypertension and pyelonephritis. The complications of pregnancy in women with diabetes include poor glycemic control during pregnancy, maternal infections such as urinary tract infections, increased risks of cesarean sections with assisted delivery by such means as forceps and vacuum extraction, again, like I said, due to fetal macrosomia, increased risk of preterm birth, maternal hypertension, preeclampsia, fetal macrosomia, and congenital abnormalities, CNS defects, and cardiac defects. So it's really important that we address these things before the women get pregnant, that we can actually prevent these complications from arising, reducing the risk of all of those things for both mother's safety and also the safety of that baby as well. Also, we wanted to talk about we can't go into all these things in too much depth, there's so much to talk about, but we often see gestational diabetes mellitus in our pregnant women. So this is, the definition of this is a carbohydrate intolerance that begins or is first diagnosed during pregnancy. Gestational diabetes mellitus, as we said before, is on the rise, and it affects approximately 5 to 8% of pregnancies in Australia. The maternal complications of gestational diabetes mellitus during pregnancy include preeclampsia and an increased risk of sections. And for the neonate, the complications include jaundice, respiratory difficulty at birth, hypoglycemia, and jaundice. And remember, the routine screening is recommended at 26 to 28 weeks, and close supervision with obstetric and endocrinology staff is required. And these are all in the guidelines. We're not making this up. This is all guideline driven. Gestational diabetes mellitus, with a diagnosis of that, after the baby's born, the woman has an increased risk of developing maternal type 2 diabetes. And this was found from an extensive population-based study. So women, I'll say it again, women who've actually had a diagnosis of gestational diabetes are actually at increased risk of developing type 2 diabetes later on in life. So what can we do, again, as primary healthcare nurses? So for these women, we need to address these women. For women with a gestational diabetes, post-delivery advice should include a healthy diet, exercise, and may include a referral to a dietitian and a physical activity program, reducing the risk of developing diabetes by 40 to 60% in those at high risk. That's a pretty impressive statistics, and that's something that we actually can directly impact. And dietitian may provide education on the benefits and nutrition requirements during breastfeeding, taking a low saturated fat diet, and returning to physical healthy activity, postpartum physical activity, and also goal setting for weight loss. The development of type 2 diabetes is also related to known risk factors such as increased waist circumference, which is maybe highly prevalent in women with a past history of gestational diabetes. So because of the increased risk of developing diabetes, women with a history of gestational diabetes should have a fasting blood glucose level every 3 years and be offered preconception advice before every future pregnancy. And I think that's something that we can really take away. So remember that. So for women that you do see who had a diagnosis of diabetes in their pregnancy, remember a fasting blood glucose every 3 years. It's important to actually protect and screen against developing type 2 diabetes.
And can I just add something in there, Ruth, as well? My feeder hospital is Liverpool Hospital, and the diabetic clinic makes the comment that a lot of women actually aren't following up in the postnatal period with their 75 gram load or glucose tolerance test. So I think primary health nurses also have that role in being able to really encourage the women to have that test done and look at where they're at with, whether that's, it's normal, or, if they're pre-diabetic, if they're needing any further management.
And I think that's something that needs to be flagged on the system. So if a woman has had a diagnosis of gestational diabetes within a pregnancy, it's something that maybe you can flag on the system in your clinical notes that 6 weeks postpartum that there's a test on, and if you can put something in your action recall list or something that, every 3 years they actually do have a fasting blood glucose level, because it's something that it's just often missed, and it's something, like I said, that we can really address and potentially make some significant inroads into. We're just going to move on to polycystic ovarian syndrome. I know Joe touched on it. The point being said is the fact that we actually do see lots of women with PCOS in our system, and it's something that's so huge. But just to be mindful of the very fact that we are going to see these women, and hopefully that you can take from this tonight that because of those increased risks of fertility, so women with PCOS may experience menstrual dysfunction, like Joe was saying, including irregular periods and amenorrhea, infertility related to less frequent or absent ovulation, hirsutism, acne, obesity, and glucose intolerance. So that's the type of things that we need to address. So hopefully we can get these women before they get pregnant, and if they're struggling to get pregnant, then obviously refer them to a fertility specialist. Try and get these things addressed in early in their diagnosis, so that they're not 3 or 4 years later down the track didn't realise that that's potentially going to affect their chances of having a family. I think it's a really important thing that we need to get that message out. So early diagnosis is important as it can allow symptoms to be managed and may prevent the development of long-term health problems such as diabetes. And for women with a BMI above 25, all symptoms will improve of PCS with some weight loss. So for those with raised BMI, provide lifestyle advice and dietary information for women with PCOS. And you may consider, like I said, a referral to a fertility specialist for ovulation induction. Consider metabolic risks such as including pre-diabetes, diabetes, and increased risks of cardiovascular disease. Like I said, actively encourage lifestyle change and provide dietary information for women with PCOS, obviously including a scheduled annual BP and BMI, and screen for hyperlipidemia and diabetes every 1 to 2 years. This is something that is on the rise. We know that we see quite a lot of women. PCOS approximately affects 1 in every 15 women worldwide, and it's on the rise. So we need to address these women and hopefully provide preconception advice so that we actually, hopefully we can identify it and do something about it long term.
Before we're going to put a polling question up, but there's actually been a question around would a HbA1c 3 months post-pregnancy be a helpful tool to check for diabetes then each 1 to 3 years? I guess all I can say from that is that through the diabetic clinic that I work with at Liverpool, they seem to want women to have that 75-gram oral glucose tolerance test around that sort of 6 to 10-week postnatal time. I'm not sure what you think about that, Ruth.
Sorry, I didn't hear you. Say that again, sorry.
There's a question that came up about a HbA1c, and it was about whether that 3 months post-pregnancy doing a HbA1c would be a helpful tool to check for diabetes in each 1 to 3 years. But I've talked about, where I work is the 75-gram oral glucose tolerance test that they tend to do.
Yeah, and I think it depends on Medicare and the billing with those types of things too. So it might be more about what you can do according to Medicare and billing as opposed to what, so that needs to be factored into it.
Yeah, so I guess look at your own, where your workplace is and what the practices are there would be the answer as well. So the polling question's up. So do you currently have a system of recall to follow up patients with gestational diabetes post-delivery? Leave that up for a few seconds. Okay, so that's coming up, as majority are no, 2/3. And so I guess that's something that, people might consider after this webinar, that they may look into that, because I think that's a really good idea. Okay, so thank you for that. So the next slide, we're going to actually have a look at a video.
So my name is Sam Reeves and I'm a practice nurse and I specialise in sexual health and women's health. So it's important to remember that women attend the general practice for any reason. So they may just be attending for vaccination or another health condition, and it's always important to remember that you can introduce the topic of their fertility at any point. So they might, for example, they might be attending for their pap smear, and they may only be coming in for that pap smear every 2 years. It's a really good opportunity to perhaps say to the woman, have you thought about having children in the future? Do you have any children already? And as part of that, you can introduce the topic of weight management. So when I see women in general practice, I might be seeing them for a pap smear. It gives me an opportunity to talk about their health screening, such as breast awareness, and ask them about their fertility. If they're concerned about their weight and their body mass index might be high, I'm able to ask some questions like, is your weight a concern for you? Have you thought about ways that you're able to look at your lifestyle to reduce your weight? And I really find that women are often really grateful that you've actually asked the question. Sometimes it's really the conversation that they needed to make really effective changes. As a practice nurse, you're able to provide a really patient-centred approach, and you're also able to spend more time with your patients and give them an opportunity to come back. Most general practices will provide the visits to the nurses free of charge or bulk billed under Medicare, and that gives you a really strong opportunity to give your patients the chance to come back and see you regularly. So you might decide together upon a few small changes. It's really important not to overwhelm the patient initially with huge change to their diet or lifestyle. So they may decide to change the type of breakfast that they're having, or reduce the amount of sugar, increase their exercise, to 3 times a week instead of once a week. Just really small changes can have a really big effect on their weight and their health. And so you're able to offer them the chance to come back, and they really tend to appreciate that. And also making sure that they understand that you're not going to belittle them or give them a hard time if they haven't lost any weight. As a nurse in the general practice, it's important to look as a patient as a whole and consider their health literacy. They may be a patient who identifies Aboriginal or Torres Strait Islander, and there are systems in place to support the practice in identifying those patients, such as the Closing the Gap program, which also gives the patients opportunity to access the dietitians, perhaps physiotherapy or exercise physiology at a lower cost. They're also able to work one-to-one with a access worker or an outreach worker to look at ways that they're able to maintain a healthy weight and increase their chances of fertility. So it's important to consider the cultural factors. There may also be other health issues such as polycystic ovarian syndrome, and we know that that's closely linked with obesity, and other factors such as contraception. It may be that they've been on the contraceptive injection for years and actually haven't had that health education about the fact that that can delay the return to their fertility. So the nurses can play a really vital role in empowering women about their health.
So I'm going to move on and talk about epilepsy. And I actually, Ruth, I didn't know that that was such a common statistic about epilepsy, I have to say. So 1 in 100 Australians have epilepsy.
That's pretty confronting, isn't it?
Absolutely, yes. Yeah. I mean, in the number of clients we see, I'm sure that some people actually don't even know that they have it.
Yeah.
So it's an interesting one, isn't it?
And because it can be of varying degrees, that's the quite sort of scary thing about it as well. Yes, and also it's something to be mindful of with young women. I know actually my daughter was diagnosed with epilepsy as a young person. It's something to be always mindful of, that it's to be something that you need to be presenting with your clinical history. So ask the questions.
Yes, absolutely, and it's a biggie in pregnancy and contraception as well, because there's lots of drug interactions that happen. So in regards to contraception and epilepsy, Some anti-epileptic drugs may interfere with the metabolism of oral contraceptives, making it less effective. This can lead to possible pill failure and pregnancy. This does not mean that women with epilepsy cannot use the pill for contraception. It means that they may need a higher dose pill. Some anti-epileptic drugs do not interfere with the metabolism of the contraceptive pill, so a low-dose oral contraceptive pill or mini pill, which is the progesterone only, can be taken. The only depot-medroxyprogesterone or DMPA and the levonorgestrel IUD of the hormonal methods are not affected by liver enzyme-inducing drugs. And in the medical eligibility criteria, it actually does talk about, drug-related, contraindications as well. So it's a really good resource. Although the emergency contraception pill is safe to use, a woman with prescribed anticonvulsant medications, which are liver enzyme-inducing, will need to take a higher dose than usual. Current family planning guidelines recommend women who are taking anticonvulsant medication take a double dose of the emergency contraceptive pill. So anti-epileptic drugs that can interfere with oral and subdermal implant contraceptives, carbamazepine, lamotrigine, which includes Lamictal, Elmendos, Lamidus, Lamogene, Lamatrust. There's a lot there in the trade names. Lamotrigine, I can't get my tongue around it. So, and others, oxycarbazepine, trileptal, phenobarbital, phenytoin, dilantin. So really the take-home message is if you have epilepsy, every pregnancy should be, as far as possible, be a planned one. Most types of epilepsy are not inherited, and the risk of passing it on to a child is small. However, it is imperative that a woman with epilepsy see her specialist, her GP, and consider review by a genetic counsellor for further information and advice before getting pregnant. The important message here is, if unexpectedly pregnant, advise patients not to stop taking their medication before consulting the doctor. We need to discuss folic acid supplementation in that preconception time, and the dose of folic acid is a little higher than normal, and it's the same thing with diabetes, as we often do recommend a higher dose of folic acid for at least 1 month prior to conception and aiming to continue through first trimester as per guidelines. When there is an increased risk of neural tube defects from anticonvulsant medication, pre-pregnancy diabetes mellitus, previous child or family history of neural tube defect, a 5 milligram daily dose should be used, as we talked about. Where there is an increase, this goes for the men too, and the males need to see their GP specialist to review their medication. For men with epilepsy who, together with their partner, are considering a pregnancy, it is prudent to consider that certain anti-epileptic drugs may reduce the production of sperm for some men, which could lower a man's fertility. So, pregnancy and epilepsy. Epilepsy is not a contraindication for pregnancy. More than 95% of pregnant women with epilepsy deliver a healthy baby, even under medical treatment. Women with epilepsy in pregnancy should be seen by obstetricians and neurologists in a multidisciplinary team environment. Obstetricians caring for women with epilepsy need to consider the likely impact of pregnancy on seizure frequency, the potential impact of epilepsy on obstetric outcomes, the role of monitoring medication levels, surveillance for congenital malformations, continuation of folic acid supplements, and the place of vitamin K supplementation. And there is a register, which is the Australian Pregnancy Register of Anti-Epileptic Drugs. Bruce, are you able to talk a little bit more about that?
Yeah, so there's a really good phone. You can phone up, and it's important. They're actually doing this massive study to look at anti-epileptic drugs and pregnancy. So encourage your women, they can log on to the Australian Pregnancy Register, they can Google it, and we'll actually have that up at the end as well, and they can log on to that and then put some details down. So it's just an important thing to actually, and they're going to follow those women through, so it's a really important resource to let your women know about.
Fantastic. So if you've got a pen out there in the other land apart from the webinar, then the number is 1-800-069-722. So offer ultrasound scans at 11 to 13 weeks and expert morphology ultrasound scans at 18 to 20 weeks. Monitor serum levels of the drugs at least once in each trimester, and a vigilance of increased seizure frequency in labour and delivery. So they're important points there. And the resources is, so there's a website called Epilepsy Action Australia. So I think that's a really interesting one, because we don't often hear about that when it comes to sort of preconception care around talking to women and men about risks for epilepsy.
And that Australian Pregnancy Register is for women who are planning a pregnancy or currently pregnant or recently given birth, so they can, like I said, they can actually follow those women through. So if you just sort of Google the Australian Pregnancy Register, or like Joe said, you can just call that number. That would be a really good link to provide advice to your epileptic female patients.
So I'll just repeat that number, 1-800-069-722. So I'm going to move on and talk about mental health. I did a course a couple of years ago around on mental health nursing, and I'm really sort of quite passionate about that, that holistic care of the women that I see, because working in a women's health centre, I only see women. But what we're seeing a lot more, and you're probably seeing a lot more in your practice, of depression, anxiety, and substance use disorder. And you can see there from the stats. So, 1 in 9 Australians will have both a mental and physical health condition concurrently. So the disclosure of a mental health issue or concern to a healthcare professional may be challenging. However, identification of concerns early can assist in the treatment and prevention of more complex conditions developing. So think comorbidities. This is very important. And often we see patients with mental health concerns who are actually overweight and obese. And so you're thinking that there's probably some chronic disease that's going on there as well. Mental health and obesity, mental health and diabetes, mental health issues with drug and cigarette use, and the impact on fertility. So think about those sorts of issues if you're seeing clients with mental health concerns. As primary healthcare nurses, we need to ensure that we create an atmosphere where women feel comfortable to disclose issues such as domestic violence, depression, anxiety, or substance abuse. So when undertaking chronic disease management plans for patients with mental health or any other chronic diseases, ask about fertility, ask about future plans for family, both now and in the future. I think we often overlook that in our mental health patients. Would you agree, Ruth?
Absolutely, yeah. And it's funny because I have a friend who works in a mental health institution, and she said that often it's just all about mental health and it's not about anything else. So all of those comorbidities and their future plans, this is something that can significantly affect their long-term health too, is infertility. So, again, we need to be asking those questions, addressing those things before they become an issue.
And the other thing with infertility is, certainly women who are living in boarding houses and who have mental health issues, and not just living in boarding houses, they may be on the street, are potentially at high risk of STIs, including chlamydia, which, as we know, can impact on our fertility. So pregnancy and mental health, I think it's again really important from that preconception time frame, if you can get the woman in at that point, although I often say that most pregnancies are unplanned. So but maybe having a preconception chat with a woman who has a mental health concern, if she's having coming in for a repeat of her medication around pregnancy and STIs and her general health. Pregnancy is a time for significant physical and psychological changes in women, and I would also add sexuality changes there as well. I see a lot of women who have experienced child sexual abuse and sexual assault in my practice, and pregnancy is a high time of sexuality and, you know, how we feel about ourselves, and often we see women who have flashbacks in that period of time. It is likely that women with a pre-pregnancy diagnosis of a mental health condition will have some changes in the condition and may experience a worsening of symptoms. Relapses and diagnosis of mood and anxiety disorders, including depression, are more common during pregnancy. Depression and anxiety during pregnancy has been linked to self-harm, suicide, substance abuse, impaired family relationships, preterm birth, low birth weight, babies, and long-term developmental, cognitive and behavioural impairment in children. So a multidisciplinary approach to care is essential. And often, if it's preconception, maybe getting a medication review, I think is often a good idea with the psychiatrist to just sort of say, are there any sort of risk factors for that client's perinatal mental health? So the multidisciplinary team might include obstetricians, neonatologists, psychiatry, mental health nurses, and also the GP and primary health nurses. Determining if the woman is receiving adequate social support and she's not isolated, because we know that isolation can be a risk factor for things like depression. Implement and maintain supportive management strategies, including pharmacological and non-pharmacological care. So with contraception, I think, Ruth, what you were talking about, where often mental health nurses are just looking at the mental health and not looking at anything else. I think contraception is one aspect of that often gets missed. And it is really important for us, if we're working with women and men with mental health concerns, that we look at the issue of contraception and also safe sex, which is what I talked about before. Also, the potential effect on mood and drug interactions. So there's no significant impact on mood amongst low-dose pill users or Depo-Provera. That can be quite subjective, though. So some women will report mood changes and others will be okay. So what we want to know is, you know, where are we referring our clients to? We should be referring anything that is not in our scope of practice to the right person. So mental health nurses will provide counselling, support, referral. There are mental health nurse practitioners as well who look at medication reviews. There are certainly services within the hospital system that looks at perinatal mental health, looking at sort of things like anxiety, depression, risk of postnatal depression and other mood disorders. Also, women with bipolar disorder can have a relapse in that postnatal period, even with sort of treatment. So it's important to know who your referral sources are. Okay, keep going.
Can I just add something to that? It's regarding the use of St. John's wort. I had an interesting case a couple of weeks ago when I actually had someone that rang up and asked, she was feeling a little bit flat and had purchased some St. John's wort over the counter at the supermarket, and was asking about, she takes the pill, because on the bottom of it in very small letters it says that you should notify or ask for advice regarding pill use and St. John's wort. So just to let you know that St. John's wort and the pill do not go together, and it can actually make the pill null and void. So it's an important thing to, particularly young people who might just be dabbling with a bit of St. John's wort, to think it might just provide some relief to them, just to let them know that it actually will counter-effect the benefits of their contraceptive pill.
That's right. That's a great point. Thanks, Ruth. So with the combined oral contraceptive pill, the dosperenone-containing pill has been marketed for premenstrual dysphoric disorder, and that's trading as Yaz, and that is a low-dose estrogen pill. Has had some controversy probably within the last sort of year or two, but I guess that's a whole other topic we could talk about, with the venous thromboembolism and the pill and pregnancy. So pregnancy increases our risk for venous thromboembolism twofold. So long-acting reversible contraceptives such as implants and IUDs, for some women, may be associated with delusions, so women with mental health issues. delusions of transmission and control during periods of acute psychosis. And I've had a couple of anecdotal, sources have said to me that there's been a couple of women who've removed their rods because they've been quite psychotic, and it's been like, something's crawling, I can't get this out, so they've removed it. So we just need to be very careful about that. And it really should be the woman's informed choice around, even though they have a mental health concern, there should be some choices around it. So patient autonomy versus risk of pregnancy when the contraception isn't maintained. We need to make sure that the woman is most capable of informed consent, and I think sometimes that can be difficult with women who have mental health concerns. So you probably all know the different resources. So Beyond Blue, there's the Black Dog Institute, there's COPMI, so you can Google all of those. I also there's e-mental health resources where, it's mainly cognitive behavioural therapy, but it actually does work very well. Beyond Blue has a lot of really excellent resources around perinatal mental health. Remember that women with chronic mental health disorders are at high risk of pregnancy and birth complications, including placental abnormalities, antepartum hemorrhages and fetal distress. And research shows clearly that during to higher levels of cortisol, which continues to be present at higher levels throughout the child's life and may well be a marker for the higher rates of anxiety and mood and behavioural disorders seen in these children. So, as I said, check out Beyond Blue and COPMI, Children of Parents with a Mental Illness, which provides great advice on parenting with a mental illness and it has a new mum, pregnancy and new dad section. So we're getting lots and lots of great resources coming through the internet. And I'll hand you over to Ruth again.
Can I just go back to Jo one more time? Jo, there's been a really good question asked by someone. Are you saying that the implant we talked about might cause anxiety, etc.?
Okay. What I'm saying, it's Joan. So I'm saying that there's some women, if they have, say, delusions or they might be out of touch with reality, for example, they might be psychotic, they may think that the rod in their arm is, it is a foreign body, but they may think that it's causing them a problem, and so they want to have it removed, they want to get it out. It's something there that they don't like. So that's been the issue with some women where they've removed it themselves because of that. But I think from my understanding, it's when they're having a psychotic episode.
And there's another question there too, Jo, as well.
Why is there the increase with the hemorrhage in those with mental health issues? Look, I would think it's probably relating, and Ruth, you might chime in, but around the chronic disease and the overweight, the obesity.
I think it's the starting statistics about comorbidities. So yes, all of those things need to factor in. Yep. It might not be the mental health disorder per se. It might actually be the comorbidities that are associated with that. Might be the increased risk factor.
Yep. So the chronicity of their health. Yep. Over to you, Ruth.
Okay, cool. Well, okay, we're just going to explore now a little bit about autoimmune disorders. So there are approximately 80 different types of autoimmune disorders with varying degrees of severity. And interesting that about 3/4 of people with autoimmune disorders are women. So obviously that's a factor considering of fertility in pregnancy. So what is an autoimmune disorder? An autoimmune disorder is when a person's immune system mistakenly attacks their own body tissue. And the two broad categories of autoimmune disorders are organ-specific, where one type of organ is affected, such as type 1 diabetes, autoimmune thyroid diseases, and inflammatory bowel disease. And non-specific, such as multiple organs, where multiple organs are involved, such as lupus, multiple sclerosis, rheumatoid arthritis, and myasthenia gravis. Autoimmune disorders tend to strike during the childbearing years, and some disorders seem to be affected by major hormonal changes such as pregnancy, childbirth, and menopause. Again, that's why it may be a time for diagnosis for some women, but it also may be the time in their life where they're diagnosed with something, but they're looking at fertility, long-term fertility. So autoimmune thyroid disease and contraceptive considerations. Realistically, one of the main considerations for birth control for any person is ensuring that the birth control meets the specific needs of the woman and her partner. And ensuring an effective form of birth control is being used is essential, particularly when a woman or a man is trying to work with their endocrinologist or GP to get their thyroid function control under control before getting pregnant. So for some women, it might be really contraindicated at that time in their life to actually get pregnant until their thyroid function is well and truly under control. And that's why contraception is so vitally important at that stage of their life. This potentially avoids an unplanned pregnancy in the midst of a significant fluctuations in the functions of their thyroid, which has the potential to affect the health of the woman and her unborn fetus. And I think that's a really important factor, is the fact that that's why it's so very, very important. Autoimmune disorders in pregnancy, what are the implications? So the implications for women, for example, with lupus, they have an increased risk of experiencing miscarriage, preeclampsia, preterm labour, birth defects, which may be caused by some medications for lupus, a low birth weight baby, and a worsening of the symptoms of her pregnancy and after the baby's born. During the pregnancy, the growing baby is nourished by the placenta, and about 1/3 of women with lupus will have antiphospholipid antibodies or anticardiolipin antibodies. And this may cause blood clots and interfere with the proper functioning of the placenta. And this is most likely to happen in the second trimester. And the impaired placenta is not able to supply the baby with sufficient nourishment, and the baby's growth is slowed. And this may require early delivery via cesarean section. It also occurs in about 1 in 5 women with lupus, and if left untreated, this condition endangers the life of both the woman and the baby. And depending on the severity, it may also require early delivery for that baby. It's important to remember that women with autoimmune diseases can safely have children, but there may be some risk for the mother and the baby depending on the disease and how severe it is. So, for example, a woman who's pregnant with lupus, like we said, has a higher risk of preterm birth and stillbirth, and pregnant women with myasthenia gravis may have symptoms that may lead to trouble breathing during pregnancy. And for some women, symptoms tend to improve during pregnancy. I remember a friend of mine who had Crohn's, and she said she felt like she could bottle, if she could bottle whatever was going on in her pregnancy. But as soon as that baby was born, she really went into a bit of a deep, dark hole because she was so uncomfortable because of the symptoms that flared up after that baby was born. So to be mindful of those, the fact that some women do improve during pregnancy, while others find these symptoms tend to flare up. And some medications used to treat autoimmune diseases might not be safe during pregnancy. So again, the message is to ensure those women, if pre-pregnancy planning is so vitally important, to ensure that medications have been run through the appropriate medical specialist to ensure that they're actually safe during a pregnancy. In pregnant women with a diagnosis of rheumatoid arthritis, some women will have a slight risk of miscarriage or low birth weight babies. However, the vast majority have a normal pregnancy without complications. Some women may experience a reduction in disease activity during pregnancy, but like we said, however, once the baby is born, the symptoms may well and truly return. One of the really important things to say about this is that both men and women with a diagnosis of rheumatoid arthritis will require a medication review. So many drugs used for rheumatoid arthritis, such as methotrexate, for example, can cause birth defects. And these medications may also cause problems even if a man is taking those medications. So again, if you're seeing males and females with rheumatoid arthritis who are considering a pregnancy, they will need a medication review to ensure that those medications that they're taking are safe during that preconception time and that they won't affect the risk to the baby.
Can I just put a plug in there for Mother's Safe in New South Wales, Ruth, which is a great service. They've also got some really good fact sheets on complementary medicine as well that they've started to put out. So check out Mother's Safe, and don't hesitate to call if you're wanting to clarify any of those medications. Yeah, that's really important. So again, getting back to thyroid conditions in pregnancy, the thyroid is responsible for functioning and has the potential to impact on both male and female fertility.
And women with pre-existing thyroid conditions should seek advice from the medical practitioner prior to taking iodine supplements. So remember, one of the preconception planning advice is to actually take an iodine supplement as well as a folic acid supplement. But obviously for the women with thyroid problems, that they need to speak to their specialist before they take any additional supplements, and that's a really important message to get across. So for males with either hyperthyroidism or hypothyroidism, fertility may be adversely affected since the sperm development requires normal thyroid levels. The good news is that when the disease has been identified and appropriately treated, fertility is often restored, just like if the thyroid was in its normal range. Also, erectile dysfunction, which is also a side effect of those types of things, and reduction of libido may also result from an imbalance in thyroid function. The good news, again, once those thyroid levels are actually stabilized, everything should hopefully return back to normal. So subclinical hypothyroidism can sometimes cause infertility and miscarriage. Therefore, it is really important that these women are treated, the women of childbearing age are treated, particularly if they would desire a pregnancy long term. So poorly controlled or untreated Graves' disease can result in serious concern for the baby's health, and this can include stillbirth, hypothyroidism, low birth weight, intrauterine growth retardation, and also prematurity for that baby. So women who have been treated for Hashimoto's disease and become pregnant, it's imperative that the pregnancy is planned and women have a well-controlled thyroid function, and the pregnancy is closely monitored by both the obstetric team and the endocrinologist. An untreated or poorly treated underactive thyroid can lead to problems such as preeclampsia, miscarriage, placental abruption, and stillbirth. And infants born to mothers with Hashimoto disease are at low risk of low birth weight, congenital defects, including cleft palate, heart, kidney, or brain malfunctions. And again, I know we keep saying it, the message is planned pregnancy, multidisciplinary care, and engaging both men and women of childbearing age, particularly with chronic disease. Be proactive and not reactive. So get the message out before they get pregnant, and hopefully we'll be able to stop some of the complications of pregnancy and issues with those babies when they're being born. I'll just hand you over to Jo.
Okay, thanks, Ruth. So I'm going to talk a little bit about asthma now for a few slides. Having developed asthma again later in my life, I can really sort of understand how it's going to impact on fertility and pregnancy, and all of the medication reviews that need to happen as well. So you probably see many women and men with asthma in your practice. It's a very common condition. So about 10.2% of the total population have asthma. So when a woman is pregnant or considering pregnancy, it's essential to have good asthma control, ensuring the best possible health for both the mother and the growing fetus. Well-controlled asthma means the growing fetus will have sufficient oxygen for normal growth and development, preventing low birth weight and premature delivery. And Asthma Australia recommends again that women with asthma see their GP or respiratory physician, as we've continued to talk about if planning to become or are already pregnant. So a good sort of way to look at that in a preconception, an opportunistic preconception counselling might be if someone's on the pill and you're talking to them about a pregnancy and they also have other things like asthma or thyroid problems. So, adding in some extra information about what it would mean if they became pregnant. So there's some good guidelines on this slide, but as well as all the routine preconception advice, women with asthma may need to review their asthma action plans, a medication review. They may need to, if they're smoking, they may need to sort of have that, again, that motivational interviewing and support around quitting, and making sure that their immunisations are up to date, particularly their influenzas. Asthma symptoms may get worse during pregnancy. However, with good asthma management, it usually settles back to normal within about 3 months after the baby is born. Simple physiology in that there is less and less lung capacity as the fetus grows. About 50% of Australian women with asthma experience some degree of temporary worsening of their asthma during pregnancy. typically between 17 and 36 weeks. The most important message to give to women is do not stop taking your asthma medication, especially the preventer or inhaled corticosteroids. Stopping the inhaled corticosteroid puts your baby at risk if you stop taking your asthma medication, because if you have an asthma attack, your baby may suffer from a reduced oxygen supply. Remember, if you can't breathe, then the developing fetus can't breathe either. And then the next slide, again, we've got another website that you can also have a look at and guide your patients through that information around pregnancy and having asthma. So just to continue on, women with complex medical conditions must be managed by a consultant obstetrician. Such conditions that we've talked about include epilepsy, neurological disorders, diabetes, asthma, renal disease, congenital or known acquired cardiac disease, autoimmune disorders, hematological disorders, obesity with a body mass index of 30 or more, severe pre-existing or past mental health disorder, and any condition for which they are under continuing specialist medical advice review. And that comes from the RANZCOG guidelines from 2014, which is the Royal Australian and New Zealand College of Obstetricians and Gynecologists. And I imagine that that's available to download off the RANZCOG website. So we're going to go to another polling question. And that is, do you think in the future you might discuss fertility and pregnancy planning to patients within your care, if that's age appropriate, when undertaking chronic disease management or lifestyle modification programs? Oh, that's excellent.
That's brilliant.
Very good. Okay. Well, thank you very much for that.
So the take-home message, could the impact of a person's fertility be the catalyst of change when advising on the immediate and long-term health benefits of weight loss? You know, as nurses, primary healthcare nurses, we're so good with patients with chronic disease management. We talk about diet and smoking cessation and exercise to lose weight, and sometimes that just might not budge them. But for people in that type of age category, that fertility is something that could be a factor. Could that be the reason that that might just push them to actually try and lose a little bit of weight, which obviously has impacts on their fertility, but also long-term impacts on their potential reduced risk of long-term chronic diseases, but also their long-term health and happiness. So preconception planning, preconception planning, preconception planning. Let's get that message out there. Let's actually have that conversation before the pregnancy occurs. And so interject that with your chronic disease management. Ask those questions. And remember that it could be simple things like when we talk about chronic disease management with in relation to diabetes, the risk factors for things like erectile dysfunction in men with diabetes is actually huge. And, you know, those types of things, if we can actually address those things and hopefully combat the issue, hopefully it will lead to fertility. And let's be proactive, not reactive. Let's actually go on the bandwagon before those people are starting to try for a baby, and hopefully for a positive outcome for everybody.
And I was also going to make the point, Ruth, that thinking about different population groups, for example, our Aboriginal Australian population, you know, that they, as a group, have, you know, an increased risk of chronic disease. So if you impact that on fertility and pregnancy, then that's increased as well for that group. Consider, you know, using interpreters for your culturally and linguistically diverse clients who are also wanting that sort of information from you as well. And just sort of input it into your practice as a whole.
Okay, are there any more questions that anyone would like to ask? And Lisa will send some questions through.
think she's not getting my...
High doses folic acid in diabetes, does that include people who have had a previous history of gestational diabetes? Had you written something, Ruth, about that prior to that? There's nothing in the guidelines?
Yeah, but I think we need to check that. Yeah,
I agree. I agree. I mean, I certainly know for women with type 1 diabetes, it's something that is absolutely included. Yeah. But I think that there is that, added risk if you've had a previous pregnancy with gestational diabetes, and it might be worth for all of those health impacts that happen.
And also for a woman who's had a miscarriage and stuff like that, it's important to factor that in as well. So all of those things need to be addressed with the GP or their specialist, and best to ask those questions again before the pregnancy. Yep.
So again, it's that pre-pregnancy planning, isn't it?
It is, absolutely.
Mm-hmm. Well, thank you very much, girls. We don't actually have any other questions unless there's something that's come through late just now, which I've just checked and it hasn't. So I would like to really thank you all, and I would like you to stay online because we do have a in-room survey. It's just a quick 8-question yes/no to answer. If you could just bear with us and try and manage to fill that in. I would like to reiterate that a recording of the webinar and a resources list with all the websites that will be emailed to you when the recording is available to APNA. And if you would like a copy of the presentation slides, if you email me at the email address that I put on your screen earlier, I'd be happy to send that to you as well. So on behalf of APNA, I'd like to thank Ruth and Joe for their time tonight, but I'd also really like to thank you all for staying with us through some technical difficulties. We'd love to see you back again, and we'll say good night. Thank you very much.
Good night.
Good night, everybody.